Welcome to Pediatric Case Review, Musculoskeletal Series. Today's lecture is a comprehensive case-based review of septic arthritis in children. This is a true pediatric emergency requiring rapid recognition and decisive management. We will walk through 15 carefully crafted clinical cases covering pathophysiology, microbiology, clinical presentation, the Cochrane criteria, investigations, synovial fluid interpretation, imaging, antibiotic selection, surgical management, neonatal septic arthritis, complications, and treatment monitoring. Let us begin. Case Study 1. Acute joint pain in a toddler. A 2-year-old child presents with a 2-day history of fever at 38.7 degrees Celsius, irritability, and refusal to bear weight on the right leg. On physical examination, the right knee is swollen, warm to touch, and held in a flexed position. The child cries when the leg is moved. Which of the following is the most likely diagnosis? Option A, transient synovitis. Option B, septic arthritis. Option C, juvenile idiopathic arthritis. Option D, femur fracture. The correct answer is option B, septic arthritis. The classic triad in toddlers consists of fever, often low-grade but persistent, inability to bear weight on the affected limb, and focal joint inflammation with swelling, warmth, and pain on movement. In this case, the combination of systemic symptoms including fever and irritability with localized joint findings such as a swollen, warm, and tender knee strongly suggests septic arthritis. Transient synovitis typically presents with milder symptoms and normal inflammatory markers. Juvenile idiopathic arthritis has a more insidious onset and may involve multiple joints. Femur fracture would be associated with a trauma history. Case Study 2. Irritability in a neonate. A 3-week-old neonate presents with poor feeding, lethargy, and fussiness when the left hip is moved during a diaper change. The infant's temperature is 37.9 degrees Celsius. On examination, the left hip is held in a flexed, abducted position called the frog leg posture, and the child resists any movement of the hip. Which finding is most characteristic of septic arthritis in this age group? Option A, high-grade fever greater than 39 degrees Celsius. Option B, polyarticular involvement. Option C, pseudoparalysis of the affected limb. Option D, normal inflammatory markers. The correct answer is option C, pseudoparalysis of the affected limb. Neonatal septic arthritis often presents with nonspecific signs due to the immature immune response. Pseudoparalysis is the most characteristic finding and refers to the resistance to passive movement that mimics actual paralysis. Poor feeding, irritability, and lethargy are common early symptoms. A low-grade fever or even complete absence of fever is typical in this age group. Polyarticular involvement does occur more frequently in neonates compared to older children, but pseudoparalysis remains the single most characteristic finding that should prompt urgent evaluation. Case Study 3. Polyarthralgia in an adolescent. A 16-year-old sexually active female presents with a 3-day history of fever, migratory polyarthralgias moving from the wrist to the right ankle, and pustular skin lesions on the hands. Physical examination reveals a right ankle that is swollen, erythematous, and exquisitely tender. She denies recent trauma. A few pustular lesions are visible on her extremities. Given this clinical presentation, what is the most likely causative organism? Option A, Staphylococcus aureus. Option B, Streptococcus pyogenes. Option C, Kingella kingi. Option D, Neisseria gonorrhoeae. The correct answer is option D, Neisseria gonorrhoeae. This patient presents with the classic triad of disseminated gonococcal infection, which includes tenosynovitis with pain on tendon movement and migratory joint symptoms, dermatitis with pustular skin lesions on the hands and extremities, and polyarthritis with multiple joint involvement that is often asymmetric. Disseminated gonococcal infection should be suspected in any sexually active adolescent with polyarticular symptoms and skin lesions, even without obvious genitourinary symptoms. It is the most common cause of septic arthritis in sexually active adolescents and young adults. Symptoms often begin with migratory arthralgia before eventually settling in one joint. Pathophysiology question. Mechanism of joint damage. A 4-year-old child develops septic arthritis of the knee. Despite prompt diagnosis, imaging shows rapid cartilage deterioration within 48 hours of symptom onset. What is the primary mechanism leading to rapid cartilage destruction in septic arthritis? Option A, release of proteolytic enzymes from neutrophils and bacteria. Option B, direct pressure necrosis from the joint effusion. Option C, ischemia from thrombosis of synovial vessels. Option D, autoimmune cross-reactivity triggered by the infection. The correct answer is option A, release of proteolytic enzymes from neutrophils and bacteria. Septic arthritis triggers a massive inflammatory response within the joint space. Bacteria invade the synovium, leading to an influx of neutrophils. These immune cells release powerful proteolytic enzymes, including collagenases, elastases, and matrix metalloproteinases, which directly degrade the proteoglycan matrix of articular cartilage. This enzymatic destruction occurs rapidly, within hours to days, and is irreversible if not promptly treated. This is the fundamental reason why early surgical drainage and antibiotic therapy are so critical. Delayed treatment allows unchecked enzyme activity, leading to permanent joint damage that cannot be reversed. Microbiology question: common pathogens by age. A 14-month-old child attending daycare presents with a subtle limp and a low-grade fever of 38.2 degrees Celsius. The child appears mildly irritable but is still playful. Physical examination reveals mild swelling of the right knee with minimal warmth. Laboratory results show only mildly elevated inflammatory markers, C-reactive protein 8 mg per deciliter, and erythrocyte sedimentation rate 35 mm per hour. Which organism has emerged as the most common cause of septic arthritis in children aged 6 to 48 months, especially presenting with milder clinical symptoms? Option A, Haemophilus influenza type B. Option B, Staphylococcus aureus. Option C, Kingella kingi. Option D, Group B Streptococcus. The correct answer is option C, Kingella kingi. The epidemiology of pediatric septic arthritis has evolved significantly due to widespread vaccination. While Staphylococcus aureus remains the most common overall pathogen across all ages, Kingella kingi has emerged as the leading cause in toddlers aged 6 to 48 months. Key characteristics of Kingella kingi include: it is a gram-negative coccobacillus and part of the normal oropharyngeal flora in young children. It often causes mild clinical presentations with low-grade fever, minimal systemic signs, and only mildly elevated inflammatory markers. It is frequently missed on standard cultures due to its fastidious nature. Detection requires inoculation of joint fluid into blood culture bottles or polymerase chain reaction and molecular testing. Physical examination question: hip joint assessment. You are examining a 4-year-old child with suspected septic arthritis of the left hip. The child is irritable and refuses to move the leg voluntarily. Which physical examination maneuver is most sensitive for detecting hip joint irritation or effusion? Option A, log rolling the leg to assess for guarding. Option B, straight leg raise test. Option C, palpation of the anterior superior iliac spine. Option D, assessing for leg length discrepancy. The correct answer is option A, log rolling the leg. Pain elicited during gentle internal and external rotation of the hip, known as log rolling, is a highly sensitive though not specific sign of hip joint pathology. In septic arthritis, the inflamed synovium causes significant pain with any movement, leading the child to guard the limb and resist this motion. This maneuver is particularly valuable because it can be performed gently without causing excessive distress to the child, yet provides crucial diagnostic information about intra-articular inflammation. A child who resists log rolling of the hip with guarding or pain must be evaluated urgently for septic arthritis, as the hip joint carries the highest risk of avascular necrosis if treatment is delayed. Diagnostic criteria question: predictive algorithms. A 5-year-old child presents to the emergency department with right hip pain and limping for 2 days. The child had a fever of 38.8 degrees Celsius at home and is now unable to bear weight on the affected leg. Physical examination reveals guarding with hip movement and tenderness over the hip joint. Laboratory results show white blood cell count 14,000 per cubic millimeter, erythrocyte sedimentation rate 45 millimeters per hour, temperature on arrival 38.2 degrees Celsius, and the child refuses to walk or bear weight. According to the Cochrane criteria, what is the approximate probability of this child having septic arthritis? Option A, less than 3%. Option B, approximately 40%. Option C, approximately 93%. Option D, greater than 99%. The correct answer is option D, 99.6% probability. The Cochrane criteria is a validated clinical prediction rule for differentiating septic arthritis from transient synovitis in children with hip pain. The 4 Cochrane predictors are fever greater than 38.5 degrees Celsius, inability to bear weight on the affected limb, erythrocyte sedimentation rate greater than 40 millimeters per hour, and white blood cell count greater than 12,000 per cubic millimeter. This patient has all 4 predictors present, which corresponds to a predicted probability of septic arthritis exceeding 99%. When all 4 predictors are present, urgent surgical intervention is indicated without further delay. The Kocher criteria are most useful for distinguishing septic arthritis from transient synovitis, which is the most important differential diagnosis in a child with hip pain. Investigations question: monitoring therapy response. A 3-year-old child with confirmed septic arthritis of the right knee has been on intravenous antibiotics for 48 hours. Initial laboratory values showed C-reactive protein of 85 milligrams per liter and erythrocyte sedimentation rate of 95 millimeters per hour. The child shows clinical improvement with reduced fever and less pain. Which inflammatory marker is most useful for monitoring short-term response to antibiotic therapy in the first week of treatment? Option A, erythrocyte sedimentation rate, because it reflects overall inflammatory burden. Option B, C-reactive protein, because it has rapid kinetics and responds quickly to treatment. Option C, white blood cell count, because it directly measures immune response. Option D, procalcitonin, because it is the most specific marker for bacterial infection. The correct answer is option B, C-reactive protein, which is superior for short-term monitoring. C-reactive protein is the preferred marker for monitoring short-term response to therapy due to its rapid kinetics. Its half-life is approximately 19 hours. It rises within 6 to 8 hours of infection onset, and it falls rapidly with effective treatment, making it ideal for monitoring over days. In contrast, erythrocyte sedimentation rate remains elevated for weeks even after successful treatment because it reflects the viscosity of blood, which normalizes much more slowly. Serial C-reactive protein measurements are used to guide antibiotic duration and discharge decisions. A C-reactive protein that fails to fall or rebounds after initial improvement should prompt reassessment for inadequate drainage, antibiotic resistance, or a missed focus of infection. Investigations question: synovial fluid analysis. A clinical scenario, arthrocentesis is performed on a 6-year-old child's swollen knee joint. The synovial fluid sample has been sent to the laboratory for comprehensive analysis. Which synovial fluid finding is most specific for confirming bacterial septic arthritis? Option A, white blood cell count greater than 50,000 cells per microliter. Option B, neutrophil percentage exceeding 90% of total white cells. Option C, positive gram stain showing bacterial organisms. Option D, synovial fluid glucose less than 40% of serum glucose. The correct answer is option C, positive gram stain showing bacterial organisms. While a white blood cell count greater than 50,000 per cubic millimeter with over 90% neutrophils is highly suggestive of septic arthritis, it is not diagnostic on its own, as other conditions can produce similar findings. A positive gram stain, although only detected in 30 to 50% of cases, is highly specific for bacterial infection. Its presence confirms the diagnosis even if cultures ultimately come back negative. An important point: molecular testing, including polymerase chain reaction, is increasingly used to detect fastidious organisms like Kingella kingi when standard cultures are negative. All synovial fluid should be sent for cell count with differential, gram stain, culture, and glucose simultaneously. Case Study 10. Imaging for hip joint effusion. A 6-year-old child presents to the emergency department with a 1-day history of right hip pain and fever of 38.9 degrees Celsius. The child is limping and refuses to bear weight on the affected leg. Physical examination reveals tenderness over the right hip with pain on passive movement. What is the most appropriate initial imaging modality to confirm the presence of a hip joint effusion? Option A, plain radiographs, X-ray. Option B, ultrasound of the hip joint. Option C, computed tomography scan with contrast. Option D, magnetic resonance imaging of the pelvis. The correct answer is option B, ultrasound of the hip joint. Ultrasound is the best initial imaging choice for confirming a hip joint effusion in children for several reasons. It is non-invasive and radiation-free, making it safe for children of all ages. It provides rapid assessment with results available immediately at the bedside. It is highly sensitive, up to 90%, for detecting joint effusions. Importantly, it can detect as little as 2 milliliters of fluid in the hip joint, making it superior to clinical examination alone. It can also guide real-time aspiration in cooperative patients. Plain X-ray is used, but is often normal in early septic arthritis. Magnetic resonance imaging is reserved for complex or uncertain cases, and computed tomography scan exposes children to unnecessary radiation. Case Study 11. Empiric antibiotic selection. A 5-year-old previously healthy child presents to the emergency department with acute onset of right knee pain and fever. The child is fully immunized, has no known allergies, and attends daycare regularly. Physical examination reveals a swollen, warm, and tender right knee with severe pain on movement. The child refuses to bear weight and has a temperature of 39.2 degrees Celsius. Laboratory results show elevated C-reactive protein and white blood cell count. Your hospital is located in a community where community-acquired methicillin-resistant Staphylococcus aureus accounts for approximately 20% of pediatric skin and soft tissue infections. What is the most appropriate empiric antibiotic regimen for this child? Option A, oral amoxicillin clavulanate. Option B, intravenous ceftriaxone. Option C, intravenous vancomycin. Option D, intravenous ampicillin sulbactam. The correct answer is option C, vancomycin or clindamycin. Staphylococcus aureus is the leading cause of septic arthritis across all age groups. In regions where community-acquired methicillin-resistant Staphylococcus aureus prevalence exceeds 15%, empiric coverage against methicillin-resistant Staphylococcus aureus is critical. Both vancomycin and clindamycin are effective against both methicillin-sensitive and methicillin-resistant Staphylococcus aureus. Cefazolin, while excellent for methicillin-sensitive Staphylococcus aureus, lacks activity against methicillin-resistant Staphylococcus aureus. Ceftriaxone provides good gram-negative coverage but insufficient gram-positive coverage for this scenario. The 2024 Infectious Diseases Society of America guidelines recommend empiric anti-methicillin-resistant Staphylococcus aureus therapy in areas with significant local resistance. Delayed appropriate therapy increases the risk of irreversible joint destruction. Treatment question: goals of surgical intervention. A 4-year-old child is diagnosed with septic arthritis of the right hip. Joint aspiration reveals purulent fluid with a high white cell count. The child is experiencing significant pain and refuses to move the affected leg. What is the primary goal of urgent surgical intervention in this case? Option A, to obtain tissue samples for definitive culture identification. Option B, to insert a drainage catheter for continuous joint irrigation. Option C, to decompress the joint capsule and prevent avascular necrosis. Option D, to perform complete synovectomy and remove infected tissue. The correct answer is option C, to decompress the joint capsule and prevent avascular necrosis of the femoral head. Septic arthritis of the hip is a true orthopedic emergency. The accumulation of pus increases intracapsular pressure, which can compromise the delicate blood supply to the femoral head via the epiphyseal vessels that run along the femoral neck. Avascular necrosis is the most devastating complication of untreated or delayed hip septic arthritis. Surgical drainage performed urgently decompresses the joint, preserves articular cartilage and growth plate integrity, and prevents lifelong disability. The critical timing rule is delayed treatment beyond 4 days significantly increases the risk of avascular necrosis. This is why septic arthritis of the hip must be treated as a surgical emergency from the moment of diagnosis. Treatment question: duration and switch criteria. A 7-year-old child with septic arthritis of the right knee has been on intravenous vancomycin for 5 days. The child is now afebrile for 48 hours, walking without pain, and the C-reactive protein has decreased from 120 milligrams per liter to 35 milligrams per liter. The parents are asking when their child can go home on oral antibiotics. What is the most appropriate criterion for switching from intravenous to oral antibiotic therapy in this case? Option A, complete normalization of C-reactive protein levels. Option B, clinical improvement with ability to bear weight and decreasing inflammatory markers. Option C, completion of exactly 7 days of intravenous therapy. Option D, negative blood cultures for 48 hours. The correct answer is option D, clinical improvement with a C-reactive protein decline of greater than 50%. The criteria for switching from intravenous to oral antibiotic therapy include: the patient must be clinically stable and improving, afebrile for at least 24 to 48 hours, C-reactive protein showing a significant downward trend of more than 50% reduction from peak, ability to tolerate oral medications, good oral bioavailability of the chosen antibiotic agent, and reliable follow-up ensured. A critical teaching point is that the decision should never be based on a fixed number of intravenous days alone. The combination of clinical improvement and laboratory normalization guides safe transition to oral therapy. This approach, known as sequential antibiotic therapy, has been validated to reduce hospital stay without compromising outcomes when the appropriate criteria are met. Complications question: long-term sequelae. A 4-year-old child was diagnosed with septic arthritis of the right hip. Unfortunately, treatment was delayed by 6 days due to initial misdiagnosis as a viral illness. The child underwent surgical drainage and received appropriate antibiotics. What is the most devastating long-term complication that this child is now at highest risk for developing? Option A, chronic joint pain and stiffness. Option B, leg length discrepancy. Option C, avascular necrosis of the femoral head. Option D, recurrent joint infections. The correct answer is option C, avascular necrosis of the femoral head. Septic arthritis of the hip creates a vicious cycle of destruction. Increased intracapsular pressure from joint effusion compresses the delicate epiphyseal blood vessels, causing ischemia and necrosis of the femoral head with eventual collapse and permanent deformity. Key prognostic factors include time to treatment is the most important factor, with best outcomes achieved within 4 days of onset. The hip joint carries the worst prognosis of all joints due to its enclosed anatomy and blood supply vulnerability. Staphylococcus aureus causes greater destruction than other organisms. Avascular necrosis can result in permanent gait abnormality, limb length discrepancy, and the need for hip replacement in adulthood. This case underscores why septic arthritis of the hip must never be attributed to a viral illness without thorough investigation. We would like to take a moment to tell you about our pediatric case review community on Patreon. If these lectures are helping you learn, you will find even more value inside the community. All lecture videos are neatly arranged by system for easy access, so you can find any topic instantly. All presentation slides are available as downloadable image files, perfect for studying and self-quizzing at your own pace. You will also join a dedicated space to connect and learn with peers who share your passion for pediatric medicine. For details on how to subscribe, comment the word info below, and we will send you a private message with everything you need to know. And that brings us to the end of today's lecture on septic arthritis in children. Let us review the 4 key takeaways. First, septic arthritis is a pediatric emergency. Maintain high clinical suspicion for any limping child with fever. Second, early diagnosis relies on clinical assessment, inflammatory markers including C-reactive protein and synovial fluid analysis. Third, treatment requires urgent surgical drainage combined with targeted antibiotic therapy. Fourth, prompt intervention within 4 days is essential to prevent devastating complications like avascular necrosis. If you found this lecture helpful, please follow the Pediatric Case Review channel for more case-based musculoskeletal and pediatric lectures. If you have any questions or comments, drop them below. We read every single one. Thank you for watching.